I'm going to talk about thoracic aortic disease, and you asked me to talk about endovascular treatment for thoracic disease. Next statement. Well, as you've already heard tonight, it used to be really the domain of cardiac surgeons. They do open heart surgery. They put people on bypass. They make these massive incisions, cut people's chests open, right? Stop their heart, stop their lungs. All those days are gone. So now it's the domain primarily of vascular surgeons, and we treat almost every thoracic pathology below, distal to the subclavian nowadays with a minimally invasive endovascular approach. Usually we don't even use an incision. It's percutaneous. They don't even usually require general anesthesia. That's, next slide. It went from that big open surgery to this, right? And that's basically the end of the question that Paul asked me to talk about. So that is the answer. That is my talk that Paul gave me. Next slide. So now I want to talk about what I want to talk about, right? So I really like I really like the emergencies of the thoracic aorta. And we haven't talked about that tonight. We did talk about dissections. Mark talked about dissections. That's an emergency. But I mean the real emergencies. Sorry, Mark. I mean like holes in your aorta, 5 liters of blood loss, blood pressure of 30. You know, that's what I'm talking about. And the outcomes of endovascular repair of a ruptured thoracic aorta, right, was published. This is one of our papers published in Circulation. That's a real emergency, Mark. That is your thoracic aorta ruptures into your chest. Now that is a manly repair. Okay, next thing. Okay, the problem is it's not great. Half of them die, all right? And that's once they get to the operating room. So in spite of being able to treat these with stent grafts, it's still better than it used to be. The mortality of open repair of ruptured thoracic aneurysms was like 80% when you got them into the operating room. So 50% is better, right? Actually, their survival is better than 50%, but 50% still need some kind of touch-up or reintervention later on. So we can usually get them to live, but then we have to keep touching them up later. They require secondary interventions. So it's not perfect. Next. And the problem is, we put these grafts in when, as I said, they've lost 5 liters of blood, their blood pressure is 30, they're almost dying. We're doing it in the middle of the night, right? We just use what we have on the shelf, which may not be the exact right size. So the conditions are not optimal, right? And because of that, the results are not optimal. They still have a lot of problems. I would say most people would be happy to be alive to have problems later on, but they still have problems. Most of the problems have to do with what we call endoleaks, or blood leaking around the outside of the stent graft. Next. Right? And just touch on that. Yeah. So the problem is, Mark, you showed a lot of, so Mark and I were fellows together. We graduated at the same time. Yes, he's at Harvard, but like we are the same age. And he showed a lot of beautiful pictures of these dissections, and they're all still. The problem is that's not real life. Real life is that our aorta is moving, right? This is my aorta, right? And you can see that when my heart beats, my aorta moves, right? And that's what happens. You're putting these stiff, non-compliant kind of metal objects. I think Richard said that look at all this metal in here. Yeah, there's a lot of metal, and it's all moving around. And you know, when you take a wire or a spoon and you just bend it back and forth 100 times, it breaks, right? Well, it's not that dissimilar in some of these metal objects we're putting in thoracic disease. Next. And you can see here's a thoracic stent graft, and it's kind of up in the thoracic aorta. And you can see as it moves, this thing's kind of bouncing around. Next slide. Right? And here's an even better picture. This is a patient that I put this stent graft in years ago. I think somewhere up there, it's in 2006. I did this in the Netherlands. That's where I did my PhD. It was in the Netherlands. And the topic of my thesis was, believe it or not, putting stent grafts in moving environments and what happens. in a nutshell, I know this was 4 years of work, but they break. So this is the stent graft bouncing up and down. This is the thoracic aorta. You know, you don't have to be a vascular surgeon. I'm sitting at a table with a family practice doctor. You wouldn't want that in your aorta bouncing up and down. Right, next stage. Because you don't have to wait too long until something like this happens. You know, here's a rupture. This guy was in a car accident, young guy. Again, this I did in the Netherlands. This guy was young, 30-some years old, car accident. This is a rupture of his aorta. And I put the stent graft in, and it collapsed. The top part collapsed. The bottom part stayed open. You can imagine that if your blood is coming up here and this is collapsed, first of all, your aneurysm is still open. You can rupture into your chest and die. Second of all, the distal part is still open, essentially blocking off all blood flow to the lower half of your body, causing intestinal ischemia and death and paralysis. And he was a lawyer. Right? Right? So we came back in. I put another stent in there, and it lasted for about a week, and then that one collapsed. And we admitted defeat, and cardiac surgery came in and took it out. Now, I will say that, and he didn't sue me, and he was a lawyer for the mafia, so I should be fine. And so the truth is, though, he came in, he was almost dead. We did get him. He was actually very happy because he wouldn't have tolerated open surgery when he first came in. Blood pressure of 30 or 40, cover the hole. We were able to resuscitate him, and he did fine. But the point is, this is a problem. Next. And talking about, you know, Mark showed a lot of beautiful dissections. Here's a type A dissection. Here's a type B dissection. You know, you're putting in these stent grafts, but it's not like that CAT scan. It's moving around, and you can see it when you're doing the angiograms and you're putting up the stent. Everything's moving around, and it's very complicated. Next slide. Right, and so, you know, you've been seeing all these pictures of moving anatomy, but there's a lot of stuff that you don't see. What you don't see is there's in the process of all this, there's blood flowing through this. It's like a garden hose. You know, when you're at home and you turn on the garden hose and all that water is squirting out of the hose? That is exactly what it's like when you open an aorta. It's exactly the same. So you don't see that on a CAT scan, but yet we are putting in, imagine taking the end of your garden hose, putting it right into your face and trying to thread a wire and a stent down there and open it up. Right? It's fraught with problems. So we should be able to fix those problems and make them better. So first of all, as we're using TEVAR, or endovascular aneurysm repair, for the thoracic aorta all the time for these kind of emergencies. We don't have an indication for it, but we still do it because we know that the results are actually better. The results are so bad with open surgery that it's hard not to be better by putting in a stent, and it is better to put in a stent. And we published this data. Next slide. And basically, you can see very similar to what Mark talked about. You know, this was what it used to be like in the early days of 1999, where everybody got an open repair, and nobody, right here would be in yellow, got an endovascular repair. And the mortality, right, was 30%. This is if they made it to the operating room. Then in the mid-era, sort of the early 2000s, you can see that the open repair starts going down, the endovascular repair starts going up, and the mortality is going down. And now, I don't think anybody does open repair, hardly ever. Maybe they still do it at MGH for some of these catastrophes. But, you know, so, but now basically everybody gets an endovascular repair, and the mortality is better, right? So next slide. And you can kind of, this is from our paper, so it's definitely true that the mortality for open repair for these ruptured thoracic aneurysms was 33%, and a little more than half of that, so the mortality was about twice as good if you did an endovascular repair. Now, these are not randomized, right? This is just our experience, but it certainly looks better, and because of this kind of stuff, the vascular surgeons just started doing it. Next slide. So this is another one. What is the best operation? We tried to figure this out. Next slide. right? So here's the trends, right? This is from New York State, and you can see again, same message, right? The blue is open repair, red is endovascular repair. Back in the Stone Age of the 2000s, everybody was doing open repair, and then all of a sudden it started shooting up, and now nobody does open repair. Next slide. And again, this was another subset of patients, but the message is the same. For ruptured thoracic aneurysms, basically, if you do an endovascular repair, you just have far, far, far better outcomes. And this is in spite of, we don't even have an approved device for this, right? So we're just using what we have for aneurysms and putting it in for ruptured thoracic cases and ruptured dissections, and the results are pretty good. Next slide. So the problem is they're not good enough. So we want to try to make it better. And this is what I wanted to talk about. I think we have made it better. And part of it is by trying to think, why do these not work? And this was part of my work. And I think our results are even better than what they're showing here. And the fact is, when someone comes in and you lose 5 liters of blood, like, I don't know how much blood you have in your body, but I guess it depends how big you are. But that's a lot of your blood. So you're hypovolemic, right? Your blood pressure is 50, and you would imagine that something must happen to the size of your aorta. Next slide. So my thought was, who do we have? What kind of experiment we could do? We could take like 5 liters off of someone and measure their aorta. And I tried to get that through the IRB at Yale, and they wouldn't allow it. Okay? So then the next best thing we could do is, we do live in New Haven, and there's like, I don't know if you guys are on Facebook, you know, that's one of the most dangerous cities in America. And there's a lot of people that are getting shot and stabbed. So we took those patients, and they lost significant amount of blood, and they had a CAT scan when they were hypovolemic, and then they did well because of our general surgery and trauma surgery colleagues. They fixed things up, and we measured their aorta. They don't have vascular disease. They just lost a lot of blood. Next slide. So what I did is we say, okay, let's take people in here that lost liters of blood that are in severe shock, right? And let's just measure their aorta, and then they get fixed, and then a week or 2 later, they get another CAT scan for another reason. Let's measure their aorta. How much does it change? Well, it actually changes in the thoracic aorta, you know, in the range of 13%. That's the middle. But there are some people that change 40%, and some people that change hardly at all. And it's the young, healthy people that change the most because their arteries are soft. And for those of us that have sewn onto those kind of young aortas, you know, you can imagine that they stretch and contract. So you can imagine, this isn't exactly right, but if someone comes in with a ruptured aortic aneurysm or ruptured thoracic aneurysm, and they're in hypovolemic shock, and you're sizing the stent graft, they got a CAT scan, you're sizing their stent, and usually we oversize it about 10%, maybe 15%, you know, so it just sort of sticks in place. Well, if then all of a sudden you save their life, and then their aneurysm, their aorta, they get the blood pressure back to normal, their aorta expands 13%, but you only put a stent graft that's 10% too big, well, then you can imagine blood would slip around the edge, and then they would have these endoleaks, the problems that we're having with these kind of patients, right? As the stent kind of moves, or blood leaks around the outside. So next slide. So that was a thought, but it wasn't very controlled, because some of these patients that get shot are not model citizens, and they have drugs and all kinds of things that make for bad control. So we thought we would do it with pigs and do the same experiment. This time we could control it. So this is another paper we did. And next slide. So here is a pig, and here is me operating on the pig. That's the pig, and that's me. And we basically used intravascular ultrasound to very precisely measure the aortic diameter, and then I took off 10% of their blood, 20%, 30%, 40%, measure them, then at 40% blood loss, which is about what you get when you rupture your aorta, I sized the stent perfectly, and I threaded it up there. I deployed a thoracic stent, and then I resuscitated them, gave back 10%, 20%, 30%, 40%, right? Next slide. And so what you can see, and this is not surprising, as you take off their blood, their diameter of their aorta at various levels, these are just different levels, their diameter shrinks, which makes sense. When you don't have that much pressure in your aorta, your aorta is going to shrink. I sized it to the shrunken aorta. I put in the stent. It looked really good. And then we resuscitated them. Next slide. And what I'm going to focus on, right, and this is just sort of the 40% range, the change in your aorta, let's call it the descending thoracic aorta of a pig, which a pig is very similar to someone that has a traumatic aortic rupture from a motorcycle accident, in the sense that most people that ride motorcycles are young, healthy men that have normal aortas. They crash them, they rupture their aorta, and then they shrink down 40%. We oversize 10 or 15%. We deploy it, and then, next slide. So this is let me just show you a picture instead of trying to explain it. This is your aorta. This is a hole in your aorta. You've ruptured it. Either you have a ruptured aneurysm, or you got in a car accident, or something. This is a catastrophe. Okay, next slide. But Mark comes in, and he perfectly deploys a stent. He seals off the hole. He saves their life. They're wonderful. We resuscitate them because he did this when their blood pressure was 50 at 2 a.m. And next slide. Now, they're resuscitated. Their aorta gets big. The stent doesn't change because it's metal. But their aorta gets big. Next slide. And all of a sudden, the blood comes back in here, and you have a type 1 endoleak. You save their life, Mark, but now they require secondary intervention. And that's exactly what we see in real life. Next slide. So, and these pictures are not good, but you can kind of get the point that this black is pointing to the stent graft, and this is the white arrow pointing to the outside of the aorta, and they're nice and lined up when they're hypovolemic, meaning they had lost a lot of blood. Then you resuscitate them, and the black here is the stent graft, the white is the aortic wall, and the yellow is pointing to the gap between the two. So we really saw this in the pigs, we saw this in the human trauma patients, and we see it in the patients that we treat for these catastrophes. And so we've made changes in our group that I think we now employ, and I think we get better results. Next slide. So, we can't really make a formula because young people's change more than old people's, but we can at least have this information in our mind. So, here's a person's aorta that has like an eggshell of calcium all the way around it. It's hard as a rock. That's probably not going to change that much in this old person, but a young, healthy person that's in a car accident is probably going to change a lot. So what do we do differently, and how do we get better outcomes in our patients that we treat for ruptured thoracic aneurysms, traumatic rupture of young people in kind of car accidents, and ruptured dissections? Next slide. Well, so what are the implications? So we've started using a lot of IVUS, so that's intravascular ultrasound, because a lot of times they come in, the reality is they come into the hospital, they've had a car accident, they've ruptured their aorta, we don't know that, but their blood pressure is 50, they're tachycardic, they get a CAT scan when they're hypovolemic, and we say, oh my God, they have a ruptured aorta. And they get resuscitated in the emergency room. By the time they get to the operating room, which might be half an hour, 45 minutes later, oftentimes their blood pressures now, they've done a good job of giving them blood, resuscitating. Oftentimes their blood pressure is back up to 120. So the size that you were trying to size it on the CAT scan when their blood pressure was 50 is not accurate. So we, in real time, resize them on the table using intravascular ultrasound, and preferentially like to use the intravascular ultrasound because that's real time. So when we size it, we know. We also know that if their blood pressure is still 50, but the intravascular ultrasound is showing their aorta, say is 2 centimeters, we know, and they're young, I tend to oversize more like 30% or sometimes even 35, 40% because I know their aorta is going to expand. That's how we've changed our practice based on some of this kind of information. Next slide. So I think that the idea is to have a problem, to identify the problem, and to try to make a solution to fix the problem. And this is one example in the thoracic aorta where I think that we've done that, and I think we're getting better outcomes. So there's more to come, but thanks for having me here, Paul.